Hi, everyone. Welcome to the PrecisCa GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. So our first case is a 65-year-old man who has muscle-invasive high-grade urothelial cancer. He gets a TURBT, transurethral resection of his bladder tumor. He has concern for involvement of a regional lymph node that's 12 millimeters in short axis. And so the question is the recommendation for a young patient with a creatinine clearance that's slightly low at 50 milliliters per minute and other comorbidities. Just to go back, this patient presented with hematuria, has a ECOG performance status of 1. His medical history is significant for hypertension, atrial fibrillation, coronary artery disease with a history of stent placement, but with a normal ejection fraction and hypothyroidism. He has a 30-pack-year smoking history, quit just last year, no alcohol or drug use, and is a retired engineer. His family history is significant for a sister with metastatic breast cancer and a brother with colon cancer, both diagnosed at a young age. His oncologic history is as follows. He underwent, after presenting with hematuria, underwent a cystoscopy and TURBT, and this showed high-grade muscle-invasive urothelial cancer. He had staging CT scans that showed one regional lymph node that was 12 millimeters in short axis, and by report, likely reactive of metastatic disease, can't be excluded. On baseline labs that you see there, creatinine clearance of 50 mLs per minute, presumably from his underlying medical comorbidities, slightly anemic at a hemoglobin of 11 and a normal platelet count. And I'm actually pause there and ask Dr. Siegel a question about reading lymph nodes in a patient like this. This is something that we talk about a lot in our own tumor boards. There's little nodes and it's measured this way. Somebody measured it in long axis, somebody measured it in short axis, et cetera. I guess the question is around the difficulty in reading clinically involved nodes in a patient like this.
Well, it's a good question. What do we do with these small or sort of intermediate lymph nodes? I'll tell you a couple of things that I do. The first thing that I do is I really take a deep dive into the patient's medical record, and from an imaging point of view. Sometimes we'll get lucky and there'll be even a hip CT or something years ago, and we can go back and see, has this lymph node been there for 10 years? Certainly that's a much more a confident sign that this lymph node is not involved with the patient's underlying urothelial cancer. If we don't have any old imaging at all, it's much more difficult for us. The options in some small lymph nodes, we can do an FNA, and then other options that we might have are MR imaging, just to look and see if there's diffusion restricting in small lymph nodes. When we do diffusion restricting in pretty much all of our abdomen or pelvis protocols, and small lymph nodes that diffusion restrict are more worrisome than ones that don't. The other thing that we could consider would be a PET study. Sometimes small lymph nodes will be FDG avid, and that may sway us one way or another in terms of how aggressive to be in terms of biopsying or following up these small lymph nodes.
Let me just ask you one quick follow-up about the role of PET scan in bladder cancer. I know we get it a lot. I'm not personally convinced that's useful, but I'm not a radiologist. I'm wondering your opinion.
I don't think PET scan is necessarily great at looking at the primary bladder cancer because we have so much problem with urine FDG uptake. But with lymph nodes, it's pretty good.
Okay.
With this
Thank
lymph
you.
node, I don't think we would be anywhere near the region of the bladder. So I think it has possibility.
And before we sort of move on with the case and treatment, I'm going to ask first Dr. Trikaki and then Dr. Abel. Do you care about this lymph node now? Is it going to change your management if he's headed towards neo-adjuvant therapy and cystectomy? And I don't remember the rest of the case, but let's say he's headed towards that way. Do you care that much? Do you work it up with a PET and a biopsy, or do you not? Dr. Trikaki.
I'm happy to answer this. So I would like to have it in my mind that there is possible a node, because down the road I would like to see how that might change as we're treating the patient with systemic neoadjuvant chemotherapy. But ultimately, my goal will be neoadjuvant followed by cystectomy and node dissection. And right now, there is a worldwide study running, the Niagara, where actually the one node and one disease is acceptable. As we're discussing with the 12 millimeter short axis, it doesn't really fit to consider as a target lesion. So the short answer will not change how we'll approach this patient.
Okay. Dr. Abel?
Yeah, so I'll provide a dissenting opinion. I do think that our radiologist, I think, would feel comfortable getting a core biopsy from this. And I do think if you establish that the patient has metastatic disease, I think, and you guys can correct me, but a lot of our medical oncologists would give 6 cycles of chemo instead of 4 cycles of chemo. And so that's what I think that maybe that the role of it would be in this patient. Again, I think we would be advocating for neoadjuvant chemo, even if this was not metastatic. So I could certainly see the point. And then the other things we would look for, things like hydronephrosis or any clinical evidence of T3 or T4 disease or lymphovascular invasion on the pathology, as far as the patients that we really try to advocate for neoadjuvant chemo.
Yeah, fair enough. And we're not really given location and how easy it is to biopsy and such. So there's a lot of speculation here. I guess my personal opinion is I would tend probably not to pursue it. I think the decision about 6 versus 4, I'm not aware there's actual data to support it. We do it because it makes us feel better, but I'm not actually aware of data to support it. But let's go on and we can see what happened here. So we do have this image. I should have called on Dr. Siegel after I had this image, but I will now, just to describe what you see.
Well, we can see here we have one axial image through a CT scan, and that there's an arrow pointing to an external iliac lymph node, just medial to the artery and vein. It's probably measuring about 8 by 12 millimeters, and it's in close proximity to the artery and the vein. I think some people might try this for an FNA for a core. It's a pretty snug area with the colon next door on one side and an artery and vein almost touching on the other. But sometimes you can hydrodissect and move things out of the way a little bit. I'd say it's probably right at the threshold of what people would be willing to biopsy, but it's not a no.
Yeah, okay. And its geographic distribution, so to speak, would be usual or unusual for bladder cancer?
I mean, it's possible.
somewhere in between usual and unusual. Okay.
I wouldn't say that is the typical location.
Yeah.
At all, but it's possible.
Okay. Oops. So really the question then is, I really just think one about approach. So you have a young patient, but with some fairly significant comorbidities, a creatinine clearance of 50. So by definition, cisplatin ineligible, although many of us will give platinum down to a creatinine clearance of 50. No hydro or anything to fix here. And this radiographic abnormality that could be consistent with a solitary regional nodal met. So maybe we can go back in terms of the recommendations. Dr. Trikaki, how would you approach this patient?
So actually, that is a perfect example. It's many patients that I'm seeing in the clinic have exactly the same description. And again, we're running this trial where patients with creatinine clearance between 40 and 60 receive split dose cisplatin gemcitabine in the neoadjuvant setting. So that is my typical approach right now: 4 cycles followed by surgery, assuming they're responding.
So let's assume this patient can't get a biopsy. So we don't know what that node is. you give the patient 4 cycles on or off protocol. If the node disappears, then you'd still proceed with cystectomy.
Correct.
Or I guess if it doesn't change at all, you proceed with cystectomy.
I still would consider that correct, because what if we have complete response based on the pathologic findings and not really radiographic findings?
Right. Assuming, yeah, obviously if the patient had growing nodal disease, that would be different, but that's pretty unusual. Dr. Abel, anything to add or anything different? Let's assume you can't get a biopsy.
No, I agree. I think proceeding to cystectomy in the absence of gross progression, I think would be standard.
Okay. And Dr. Shaw, I assume because of this suspicious node, there'd be no role for chemo-RT in a patient like this.
It's a good question. I would have said 5 years ago, you're correct. There is growing data on actually treating node-positive patients with chemoradiation, and you can basically treat the pelvis to a standard dose, and then you can boost the involved node if it's suspicious to tolerance with respect to bowel. So this is being done. That being said, in my experience, most of these patients would get surgery. So it's only in patients who aren't able to get surgery that we would consider that approach, but that can be done.
And if the patient gets neoadjuvant therapy, goes to cystectomy, lymphadenectomy, and has a positive node or two, what's the role of adjuvant radiation in that circumstance?
I would say it's controversial. I think that if you look at the guidelines, it allows for adjuvant radiation for T4s, positive margins, nodes, but that it's not 100% something, and it certainly comes with side effects. Both side effects to the pelvis, but also if there's a conduit created, potential toxicities to that conduit as well. So I don't think it's an absolute, but we'll discuss the pros and cons with patients based on their pathologic risk factors.
Okay. So just to sum up for this case, young man with T2 TCC, a suspicious radiographic finding of a node. I think the general consensus was potentially biopsy if it would change management, but certainly neoadjuvant cisplatin-based chemotherapy, potentially with cisplatin or whatever is going to get the patient through, standard cystectomy, lymphadenectomy, and then consideration of adjuvant radiation depending on pathologic features.